So let's begin our discussion about diuretics with osmotic diuretics. So as the name says, we're going to use osmotic forces. So we're going to use solute forces to drive diuresis. So to begin, we're going to start out with the prototypical drug. Prototypical drug isn't going to include all of them, however this is the main one associated with it. So we're going to have mannitol. Mannitol is going to be the prototype drug for an osmotic diuresis. So how does it work? So let's talk about its mechanism of action. Well, the mechanism of action is going to be it's going to be filtered by the glomerulus. So we have our glomerular filtration rate. Mannitol, there's two N's, will be filtered. So we've got our glomerulus, here's our proximal, here's our descending loop of Henle, ascending, DCT, and collecting duct. So this is the proximal collecting tubule, distal collecting tubule. This is our glomerulus. Mannitol will be filtered. It can pass through the glomerulus. However, it's not going to be reabsorbed. It doesn't get reabsorbed from the lumen. So we're going to have a lumen. So inside, here's our lumen. Here's our mannitol, M for mannitol. Typically, you're going to have sodium, and that sodium is going to leave. It'll get reabsorbed, and water will follow. And that is how the kidneys work. It's going to take solute concentrations. We're going to move our sodium from inside. Now we're going to have a whole bunch of sodium outside. And let me delete this. So we just moved our sodium from inside the lumen to outside the lumen. Our water is going to follow. We're going to use that osmotic gradient. We're going to draw that water in. However, we just gave mannitol. All that mannitol gets passed through the glomerulus into the lumen. So now we're in the lumen, and it's going to create another solute gradient. Water isn't going to want to follow as much. So sodium, potassium, chloride, all of this will be more likely to stay in the lumen, and you can get in hyponatremia as a result. However, water isn't going to want to leave as much because we have this gradient, a solute gradient. We're introducing more solutes into the lumen. More solutes, water will want to stay because it'll want to stay with the solutes. We'll have less sodium reabsorption, we'll have less chloride, we'll have less potassium reabsorption. This is mannitol is excellent for the water-soluble segments. It's because water then will want to stay inside. It'll make you pee more. That's the point. Osmotic diuretic. It's going to use osmotic forces, so solute forces, to draw water into the lumen, causing you to pee. It'll decrease your, or it'll increase your urine outflow. So the number one location is going to be your proximal convoluted tubule. That's going to be where most of the reabsorption takes place. This is going to be the main site of action. Also, remember I said all the water-soluble segments of the nephron are going to be where mannitol acts. So we have the proximal convoluted tubule. You also have the thick ascending segment. You also have the distal collecting tubule. You also have the thin descending segment. All of these locations are where mannitol can act. The number one is going to be the proximal convoluted tubule. So what are some uses? For mannitol? So an osmotic diuretic. Well, we're going to increase renal blood flow. Well, why do we do that? Well, let's go back to our figure. We're increasing renal blood flow because we're putting water into the lumen. We're reabsorbing less. We're going to increase our output of urine. And that's because we have an increased solute gradient. We're going to keep fluids going through the lumen of our nephron, and thus we'll pee more. We're going to increase our flow. So increased renal blood flow. Why do we get increased renal blood flow? That seems a little odd. Well, no, it really doesn't. It's because when we diurese, we're getting rid of fluids. That's the point. However, our intravascular, our blood, doesn't like it. our blood detects that we're getting rid of some of the water. Typically, we'd be reabsorbing some of that water, putting it back into the bloodstream. However, we just got rid of that water. So now our blood has decreased water. Well, that decreased water is compensated because cells, oops, that's not how you spell cells. Cells will shed some excess water. The cell's intracellular water supply will decrease. The cells will put off some water to increase the blood water levels, the interstitial levels as well. So we're going to swell the extracellular environment. So if we increase extracellular environment water, remember the cells are getting rid of some of their intracellular water to make up for the extracellular environment, and that extracellular water will eventually make its way to the bloodstream, increase the blood water content, and this is how we get increased renal blood flow. Not red blood cell, renal blood flow. And why do we get that? It's because we have increased blood flow to the kidneys, because we increase our blood water volume since our intracellular volume is shrinking. So that intracellular volume shrinking is also used for cerebral edema. If we have cerebral edema, we want to get rid of some of the water that's inside your brain. And inside the brain cells, what we'll do is we'll decrease intracellular volume so the brain swelling will decrease. Same volume or same principle up here as increasing our renal blood flow. So we're going to expand that extracellular environment that'll get taken up into the bloodstream. We're instead moving water from your brain and the brain cells, and now we're going to redistribute to the blood flow, so the whole system instead. So that's going to be one of the main uses. I would star this. Mannitol is going to be used for emergency cerebral edema. If you don't relieve this, you could have brain damage due to the intracerebral swelling. Your cranial bones don't like to have much give. So if you increase intracranial pressure, you can have neurologic problems develop. So that's the basics of mannitol. Now let's move on to a different diuretic. Let's move on to loop diuretics. Loop diuretics are going to be your main diuretic. I would star this one because it's going to be a major player in the diuretic arsenal that doctors have. So how do loop diuretics work? Well, first let's talk about the prototypical drug. The prototypical loop diuretic is going to be furosemide. When you think of a loop diuretic, you're going to use furosemide as kind of like your mainstay example. So loop diuretics are also known as NKCC diuretics, and that simply stands for, well, they'll be NKCC inhibitors because an NKCC is going to be a transporter of sodium, potassium, NK, chloride times 2 ions. So we're going to move a sodium, we're going to move a potassium, and we're going to move 2 chlorides. It's going to be an NKCC transporter. So if we inhibit this, we aren't able to move these ions. So that's kind of the basics. So now let's actually look at the mechanism of action. And to do that, let's start with a new one because we'll need all the space we can get. We're going to start with a typical cell in the kidney. Now, where are we going to see this? This will be in the ascending thick loop. So the thick ascending loop, because remember we have our glomerulus, proximal convoluted, descending, loop of Henle, thick ascending. This is where we'll be acting. And we also have the distal convoluted and then the collecting duct. So we have the thick ascending segment. This is a cell that we're looking at. We're looking at a cell from the lumen and from the nephron here. So here's our cell. Here's our lumen side. Here's going to be our interstitial. Here's our interstitial side. I'm going to make my thing smaller. Okay, so we may also see it in the proximal convoluted tubule as well. We may also see it there. However, this is going to be number 1. So what do we have? Well, we have this transporter, like I said. And what it's going to do is it's going to take sodium, it's going to take potassium, and it's going to take 2 chlorides. And what it's going to do is it's going to move it into the cell. We're going to move these ions from the lumen, and we're going to reabsorb it into the cell. And from that cell, it'll eventually make its way into the interstitial space. Interstitial space is reabsorbed back into the bloodstream. So we reabsorb it. Stuff that stays in the lumen goes into the urine. So if it stays in the lumen, it'll eventually get excreted in the urine. So we've also got another pump out here that's called the sodium potassium ATP ACE. And what this does is we're going to put a potassium inside the cell. We're going to pump out a sodium, and this is going to require ATP. It's going to be an ATPase. We're going to cleave phosphate off of that ATP molecule, and in the process, we're going to move a sodium out and a potassium in. So this is the sodium-potassium pump. So looks like potassium's moving into the cell, or potassium's being actively moved into the cell. So somehow we got to get potassium balanced out, and that's through this channel. Potassium will leave through a channel, and this is going to be a channel, so it's not going to require ATP. Then also we've got one more transporter over here, and it's going to be a symporter. What is a symporter? It's going to move 2 ions in the same direction, or 2 or 3. This is a symporter as well. It's going to move 3 ions in the same direction. This is a symporter, and it's going to move 2. We're going to move potassium outside the cell, and in the process we'll drive the chloride. So we're actively pumping in chloride and pumping out sodium. The sodium is just going along its gradient on this. Potassium is going along its gradient too, because it's coming into the cell, it's being pumped into the cell, and as such, it'll leave through a channel. However, potassium, as you know, likes to be inside the cell, so it'll make its way back into the cell. And once it's inside the cell, it can also leave the cell through the symporter. But why do we want it to leave? It's because we can draw those chloride ions back into the bloodstream, because we're bringing chloride ions from the lumen, so that potassium is going to be a major player in this system. So hopefully you're kind of thinking, here's the NKCC pump, the pump that we just talked about dealing with loop diuretics, because loop diuretics are also known as NKCC inhibitors. So where does this diuretic act? We're going to block this pump. If we inhibit the NKCC pump, we're going to have a loss of potentials. We'll still be bringing potassiums into the cell. Oops, not sure how that happened. Still going to bring it into the cell. However, our net result will be we'll have more solutes in the lumen. This pump still works. This symporter still works. This channel will still work. We're missing our pump. So we're pumping out sodium. We're pumping in potassium. We're not able to resorb as much stuff from the lumen, however. So all this stuff will be staying in the lumen. We're not able to bring it back into the cell. So our net result is going to be more solute in lumen. Well, what does that mean? More solute in the lumen means water will follow through its osmotic gradient. That'll be the diuretic portion of it. So more water will go to the more solute side of the lumen. We will have diuresis. Also of note, this potassium. So we've got a whole bunch of these cells kind of lined up with each other. Not just this one in existence. We've got a whole bunch of these cells. This potassium leaves through a potassium channel, and this creates a positive charge. So all this potassium is positively charged. And we're going to have a positively charged lumen. You're going to have some other molecules here. You're going to have some magnesiums. You're going to have some calciums. Magnesiums and calciums, these are also positively charged. These will be divalent cations. what will happen is when you have potassium leaking out, this causes a positive potential, this positive charge in the lumen. And what this will do is this will drive the reabsorption of calcium and magnesium. And this will happen between the cells. It actually doesn't go through the cell. So if you have a loop diuretic, you're going to have all these solutes in the lumen. You're going to have less potassium that can diffuse out to the cell. You're going to get an impaired reabsorption of calcium and magnesium. So loop diuretics will also increase the excretion of the positively charged divalent cations, so calcium and magnesium. Okay, so why do we use loop diuretics? What are some of the uses? Well, it's going to be a diuretic. I mean, it's in the name, diuretic. Everything that we're talking about is going to be used as a diuretic. However, this is going to be specifically, you're going to use loop diuretics as a mainstay, not as a number one option in the United States at least. However, it'll be used for chronic heart failure patients. If you hear chronic heart failure patients and they have high blood pressure, you're going to be thinking furosemide. You're going to be thinking loop diuretic. Also, if the patient has edema, thinking they have that hypertension, that's why you use diuretics if they have edema and hypertension. But also in heart failure patients, it'll decrease the workload of the heart in heart failure patients. There are some adverse effects. You're going to see ototoxicity. It's going to be toxic to the ear. Furosemide, you're going to be monitoring for ototoxicity. And this typically occurs only in IV use, so quickly administering furosemide. Oral route typically is a slower administration, so you won't have as high of a risk for ototoxicity. Also, decreased sodium, decreased potassium in the bloodstream, because remember here we're getting rid of sodium. This stuff cannot get reabsorbed back into the cell. That means that we're going to have an increased loss, because everything that stays in the lumen gets lost in the urine. And if we can't reabsorb this sodium, if we can't reabsorb this potassium, this chloride, we're going to lose it in the urine. And that means we're going to have a decreased sodium and potassium in the bloodstream, which leads to our decreased sodium and decreased potassium. So now let's move on to a different diuretic. We're now going to cover thiazide diuretics. And this also will include thiazide-like diuretics. So the prototypical drugs that we're going to be talking about are going to be chlorothiazide, and then metalazone. These are going to be your two prototypical thiazide or thiazide-like diuretics. So what are we talking about? We're going to be talking about diuretics that work on the distal convoluted tubule. So remember, we have our glomerulus, proximal, descending, loop, ascending, distal, convoluted, and collecting duct. We're going to be talking about our distal convoluted tubule here. So let's take a look at the mechanism of action of a thiazide diuretic. We've got our big cell here, and I'll need to make this smaller. Okay, so we've got a lumen, and we've got a interstitial. This luminal side, everything that gets stuck in the lumen will get excreted into the blood. You'll have more cells like here and more cells here. We're just taking a little snapshot of a single cell lining that lumen. So we've got the luminal side, and we've got the sodium-potassium pump. The sodium-potassium ATPase. What it's going to do is it's actively going to secrete sodium into the interstitial space. It's going to actively pump potassium back into the cell, and it's going to require ATP in the process. We've also got another channel here. It's going to put calcium 2 plus. I think I should probably redo that one. Calcium 2 plus, and it's going to pump it out and allow us to reabsorb it. We're going to allow calcium to be reabsorbed. We're also going to use that by driving the sodium gradient. So we just created a sodium gradient by actively using ATP to pump it out of the cell. Now we're going to use that sodium gradient to drive it into the cell. In the meantime, we're going to bring calcium from inside that cell into the rest of our body so we reabsorb it. Got a third pump here. We're going to take calcium and we're going to exchange it for a hydrogen ion. And this is going to require an ATP as well. So this is going to be our sodium, or not our sodium, our calcium hydrogen antiporter, meaning they're in the opposite direction. We've got some other channels that we have to worry about. This is all in the distal convoluted tubule, remember. So we've got sodium, we've got chloride. Both are going to be driven into the cell through this channel, through the membrane. So we're creating our sodium gradient. We're pumping sodium out into the interstitial space. So that creates like a little vacuum inside the cell for sodium. It's going to drive the sodium that's in the lumen to be reabsorbed. That's how we reabsorb sodium. And where sodium goes, water goes. So that is going to be how we reabsorb water, is we're going to actively pump out the sodium. That means we're going to draw in sodium from the lumen into the cell. That'll mean water will follow. So this is our sodium chloride symporter. Then also we've got a channel. We've got a channel here. And this is going to be called the TPVR5 channel. The TPVR5 calcium channel. What this is going to do is it's going to allow us to move calcium into the cell. So look here, we're using ATP to actively drive calcium into the interstitial space, which creates a vacuum inside the cell. So we're going to use a calcium channel to bring calcium from the lumen into the cell so we don't lose the calcium. So why am I even covering? This is normal physiology right here. Well, for thiazide diuretics are going to act in a couple different locations. They're going to act on this channel, this symporter. And they're going to inhibit this symporter. So if we can't bring sodium into the cell, water can't follow. Water will follow this sodium that's still in the lumen and will pee it out. So if we inhibit this channel, sodium can't get reabsorbed. Also, we have an action here on this channel, and we're going to increase this channel's ability. I don't know why I wrote decrease. We're going to increase this channel's ability. We're going to be able to reabsorb more calcium, and as such, we're going to increase this pump, and when we increase this pump through a thiazide diuretic, we're going to increase more calcium. So our net result is we're going to have decreased sodium. Increased sodium in the urine, however, we measure sodium in our blood. So we're going to have less sodium reabsorbed because we lose this channel, so all the sodium stays still in the lumen. We pee it out. So we're going to have less sodium in our bloodstream. Then we're also going to have increased calcium because remember, we're activating this channel then, increasing the calcium, we reabsorb more. So that's good in someone with osteoporosis, for example, or with a calcium deficiency. The use, I'm going to get back to my medium size. We've got the use. So why do we use thiazide diuretics? Well, it's good for chronic heart failure. It's good as a diuretic, and it's the number one first line agent. Hydrochlorothiazide, chlorothiazide, whatever you want to give. Thiazide diuretics are typically used as a first-line agent. I'm going to preface that by saying it's in the United States. Every country kind of has their own guidelines. Some prefer other diuretics. However, in the United States, it's been found that thiazide diuretics are going to be our number one first-line agent for a non-complicated hypertension. Okay. If they have heart failure, it's a different issue. We may start off with a different one if they have other issues. However, this is going to be your number one starting point for a diuretic. Also, it'll be used for calcium nephrolithiasis. So, what is calcium nephrolithiasis? Simply meaning a kidney stone that is made up of calcium due to high calcium levels. If you have high calcium levels in the lumen, you can get calcium kidney stones. So what you'll be doing is you'll be giving a thiazide diuretic that'll decrease the luminal calcium, and it'll decrease your chances of getting a calcium kidney stone. Okay, so let's move on to a different type of diuretic. So let's begin our discussion with amiloride diuretics. So let's talk about the basics of the amiloride diuretics. We'll talk about its mechanism of action. So what is it basically doing? Well, it's going to be blocking the renal epithelial sodium channels. Well, what does this tell us? Well, this sodium channel is called the ENaC channel, and we're going to be talking about the distal convoluted tubule and the collecting duct. That's going to be the primary location. So let's take a look of what's going on with the amiloride diuretics. We've got our glomerulus, we've got our proximal convoluted tubule, our descending loop, ascending, distal, convoluted, and collecting duct. That's kind of the basics. We're going to be focused primarily on the distal and the collecting duct, and also the area in between. So what we're going to be doing is the amiloride diuretic blocks the sodium reabsorption. Reabsorption meaning the sodium that's found in the lumen gets reabsorbed and goes back into the bloodstream. So we're going to block that sodium reabsorption, and it's not going to affect the potassium. So no potassium affected. So potassium can still get reabsorbed. So let's take a look even deeper now. I've got a cell, got another cell, got another cell. There's just a whole line of cells. So we're just taking a picture snapshot of one cell. We've got a lumen side, we've got an interstitial side. The lumen side, whatever is left in the lumen by the time it passes through the kidney, gets excreted into the urine. Whatever is in the interstitial side gets reabsorbed into the bloodstream. So we have a luminal side and an interstitial side. We have a channel in here, and it'll be called the ENaC channel. And what we're going to be doing is we're going to be taking sodium, and it will reabsorb the sodium. And we've got a pump over here that we've already covered, the sodium, potassium, ATP ACE. So we're going to cleave an ATP, and what this does is it's going to reabsorb our sodium. We're going to dump our potassium back into the cell, and it's going to require ATP in the process. So we're creating a sodium gradient using this NaK ATPase, so the sodium potassium ATPase. We're pumping the sodium out, which creates a vacuum. We're going to bring the sodium in through the ENaC channel. Now, I've already alluded to that we're going to block the renal epithelial sodium channel ENaC. So amiloride diuretics are going to block this channel. That's where the diuretics mechanism of action works. So we block that luminal channel. We've also got a potassium channel here. So potassium can leave. And if we block this sodium channel, what will happen is you can get you lose sodium. You lose sodium, so you'll have possibly a hypokalemia. The amiloride diuretics are known as potassium sparing. They're known as potassium sparing diuretics. Also of note that amiloride should not be used as monotherapy. They should be combined with other agents, possibly a potassium loss diuretic. So a non-amiloride diuretic, so possibly like a thiazide diuretic. Okay, so these are going to be your potassium sparing. Also, you'll have spironolactone be an example of another potassium sparing, but we'll get to that. So you've got this potassium sparing diuretic. We're not able to absorb our sodium. It gets lost in the urine. There's our hypokalemia. It's not going to affect our potassium levels. We might actually get hyperkalemia. Emia, meaning found in the blood. So we're going to have possibly excess potassium in the bloodstream because we're sparing all this potassium. We're not getting rid of it into the lumen. So we're going to have a possible hyperkalemia as a side effect. Okay, so let's move on. Now let's talk about another type of diuretic. This one's going to be a carbonic anhydrase inhibitor. So this carbonic anhydrase inhibitor, we have a lot to talk about. So I'll try and break it down into different portions. So what is a carbonic anhydrase inhibitor? Well, the prototypical one is going to be acetazolamide. That is going to be your prototypical acetazolamide. And I want a buzzword here. When you think glaucoma, you want to use a carbonic anhydrase inhibitor. So if you hear a patient has glaucoma, you need to keep this in your arsenal. You need to be thinking possibly a carbonic anhydrase inhibitor. That's just the buzzword. Let's go into the mechanism of action for these carbonic anhydrase inhibitors because it's good to see how they work. To begin, we're going to be starting with the normal physiology. There is a lot going on here, so we'll have quite a few slides. Try and stick with me, and together we will make it. So here's our cell. It's a fat cell because there's a lot going on. We'll need all the space we can get. Here's another cell and another cell down here. Okay, all good. So we're taking a look at the cells. So the mechanism of action for our carbonic anhydrase inhibitor is this carbonic anhydrase is an enzyme, and what it is it's required for bicarbonate reabsorption, HCO3 reabsorption, and this is going to be found primarily in the proximal convoluted tubule, so the PCT. So the proximal convoluted tubule, if you've been watching my other videos, here's my glomerulus, PCT, descending, ascending, distal convoluted, and then collecting duct. So we're going to be dealing with the proximal convoluted tubule. And here is the reaction that carbonic anhydrase deals with. We're going to take our, let's see, bicarbonate, and we'll be able to form carbon dioxide and water, and also note that it is reversible. This enzyme simply takes carbon dioxide and water and changes it into a bicarb form, or vice versa. So our carbonic anhydrase, remember I said it's used for bicarb reabsorption, and it's also used for bicarbonate formation and reabsorption. Okay, let's figure out how this all pieces together. I can say this till my face is blue, but if you don't understand, I didn't do my job. So the carbonic anhydrase inhibitors. Remember, it has to deal with the HCO3. So I'm going to get as small of a pen here because we have a lot to fit on. We've got an NAK ATPase. I've been talking about this pump for quite a few times now. If you've been watching my other videos, what it does is it pumps a sodium from inside the cell out, and it brings a potassium in. I have a video about the ATP, or this NAK ATPase, so if you don't understand it, be sure to watch that video. It's going to require ATP. So we're actively pumping sodium out and potassium in. So we're going to use energy. We've also got another pump. It's going to be a sodium and a hydrogen out. So it's going to be another pump or a channel, and it's going to allow sodium to come in, because here we're pumping sodium out. It's going to create a vacuum, and the sodium is what's going in the vacuum, and in the meantime we're pumping out a hydrogen ion. Now that hydrogen ion is out in the lumen. Here's our lumen. Here is our interstitial space. So the interstitial space will get reabsorbed into the bloodstream. Anything that's in the lumen will go out in the excretion, so in the urine. So in the meantime, our sodium is coming into the cell and our hydrogen is getting out of the cell. Our hydrogen is going to combine with bicarbonate. So remember, I'm going to go back. Here we have bicarbonate reabsorption. So this is the reabsorption part. So we have bicarbonate in our filtrate from our glomerular filtrate, so our GFR, and we want to get that bicarbonate back into the blood. We don't like losing bicarbonate. So we're going to take that hydrogen ion plus this bicarbonate, and what we're going to do is we're going to use the carbonic anhydrase enzyme. And this is going to convert the bicarbonate plus a hydrogen ion into H2O plus CO2. Remember, it was this reaction. It's reversible. However, in the lumen, we're going to drive it to the formation of water and carbon dioxide. This carbon dioxide is going to go into the cell, and it's going to find water that's inside the cell. This is going to be turned back by carbonic anhydrase found inside the cell. So, and it's going to be turned into a hydrogen ion, and it's going to be turned into a bicarbonate, HCO3 minus, a bicarbonate. This hydrogen is going to go back out. So, I mean, we're just looping. We're looping that hydrogen. It likes this cycle. We're not creating hydrogens. We're not losing. This hydrogen will get reused. This bicarbonate, we just simply moved bicarbonate from the lumen into the inside of the cell. Now we have a channel here that'll allow us to reabsorb bicarbonate, and then our bicarbonate is now into the interstitial space. In the interstitial space, it means that it gets reabsorbed into the bloodstream. So we have a sodium hydrogen antiporter on the luminal side. Note that it is dependent on this sodium potassium ATPase. Also, we have a symporter. So sodium. So once we have this bicarbonate in the cell, we have a symporter to get it back into the interstitial, or like the interstitial bloodstream, and that's going to be our sodium bicarbonate symporter. So look at this system. We have carbonic anhydrase enzyme. This is just the normal physiology right now. This is going on right now in your body. We're reabsorbing bicarbonate through carbonic anhydrase. We have a luminal side. That luminal side is actually kind of on the luminal membrane. It's not just floating around there. No, it's going to be on the luminal side. We've also got carbonic anhydrase inside the cell. So that's what's going on right now. If we inhibit this carbonic anhydrase enzyme, I mean, it's right there, but if we inhibit that one, or if we inhibit that one, that's what a carbonic anhydrase inhibitor is. That's what the drug does. It inhibits carbonic anhydrase. We're going to lose that bicarbonate that's in the lumen because we're not going to be able to reabsorb it. We're not going to be able to turn it into carbon dioxide, turn it into a usable form, turn it back into bicarbonate, and then pump it back into the cell. No, we're going to lose it in the lumen. So if we inhibit carbonic anhydrase, we're going to decrease blood HCO3 bicarbonate. So we're going to lose part of that buffer system. Let's continue on here. We've got a little more to go. So we just covered the bicarbonate reabsorption. But back here, I said it's also carbonic anhydrase is used for bicarbonate formation. So let's cover that portion really quick. There's two different mechanisms for that. So we've got our cell still, same cell. We've got a HPO3. Change my size here. HPO3. We've got an HPO3, and what we're going to be doing is we're going to be taking water that's inside the cell naturally. We're going to be cleaving it into two products, an OH and an H. So we're going to take that hydrogen ion, it's going to leave the cell, it's going to form, or it's going to combine with HPO3, it's going to form H2PO4 negative. We're going to lose that phosphate group. That gets lost in the urine. So this is lumen. This is going to be interstitial. So same process, our HPO3 forms with that hydrogen ion that's formed, that gets pumped out of the cell, and now we're going to be dealing with this OH. Carbonic anhydrase enzyme is still present in the cell, and then that can catalyze the reaction OH plus CO2. Cells produce CO2 and combines those to form bicarbonate, HCO3. The bicarbonate is formed. That is formation. Formation. Not spelling, because my spelling is horrible. That is formation. So we just formed some bicarbonate using by losing a phosphate in the process. Also, we've got another cell. By a similar mechanism, what we're going to be doing is we're going to be taking amino acids and metabolism in general, and we're going to have some products. We're going to have some products of metabolism and amino acid breakdown. And some of those products are going to be NH4 and a hydroxide ion. So this NH4 will get converted into NH3 and hydrogen ion. They'll leave the cell. They'll reform back into NH4. Our body doesn't like nitrogens because our body doesn't like nitrogens. I'll leave it at that. So we're going to get rid of the nitrogen. However, we are going to deal with this hydroxide again. Remember, we just covered it. We just turned to hydroxide, used some carbonic anhydrase. So we're going to take that CO2 formed by metabolism of the body. We're going to use carbonic anhydrase enzyme. We're going to form an HCO3. That is going to leave the cell into the interstitium again. So as a net result, we get rid of NH4. We add HCO3 to our stockpile. Before we got rid of a phosphate, we gained a bicarbonate. Now we're getting rid of a nitrogen and we're gaining a bicarbonate. Either one is involved in bicarbonate formation. Okay, so that's some of the mechanisms of action. We talked about the bicarbonate formation, we talked about the bicarbonate reabsorption. So let's talk about the use. The use of carbonic anhydrase inhibitors. So let's look back here. If we inhibit this carbonic anhydrase enzyme, we don't form the bicarbonate, and likewise, we're not able to form bicarbonate if we inhibit this carbonic anhydrase. So why would we use carbonic anhydrase inhibitors? Well, it's going to increase solutes in the urine, or in the luminal side. So in lumen. So what happens? We're going to increase the bicarb HCO3 in the lumen. And what this is this is going to go to the macula densa. The macula densa cells, and that's going to increase solutes in the lumen, and as those solutes pass by the macula densa, they'll be sensing the solute level passing by it. And if you have increased solute levels, you'll have decreased renal blood flow, because you don't want to peeing stuff off. If you have increased solute levels, you'll want to conserve water, so you'll have decreased renal blood flow as a result. Also, increased bicarbonate in the urine excretion causes increased secretion of sodium, potassium, and chloride. And so where bicarbonate goes, these go. And where these go, water goes. So when you get rid of bicarbonate, you'll also get rid of these ions. And when you get rid of these ions, water will go through its osmotic gradient. And thus you diurese, you lose water. So we'll go back to the uses. I didn't really talk about the uses. So we have the diuretic. It's used as a diuretic. So kidney. Also remember at the very beginning of this lecture, I talked about glaucoma. Increased pressure of the eye. So carbonic anhydrase is found in the ciliary body. You know, carbonic anhydrase inhibitors, not really used as diuretics. This is where they're really used in ophthalmology and eye management. The ciliary body of the eye is going to produce aqueous humor. So the aqueous humor is going to go to the anterior chamber, and it's going to make its way around the iris and then eventually drain. However, in glaucoma, you make all this aqueous humor, but you can't drain it, so you increase interocular pressure, the anterior chamber pressure. So you would use carbonic anhydrase inhibitors to block the carbonic anhydrase found in the ciliary body. So you're going to decrease the production of aqueous humor, thus relieving the symptoms. Also, you're going to use carbonic anhydrase inhibitors in altitude sickness. So for the treatment of altitude sickness, well, you're scratching your head thinking, how in the does that work? So let's go over that really quick. The choroid plexus. The choroid plexus. So let's go back to anatomy and physiology. The choroid plexus is involved in the development of cerebral spinal fluid, and it's found in the ventricles. So the choroid plexus contains carbonic anhydrase as well. Ciliary body contains carbonic anhydrase, your kidney contains carbonic anhydrase, your choroid plexus in the development of cerebral spinal fluid contains carbonic anhydrase. So in altitude sickness, if you go up to altitude, there's decreased oxygen in the air. And you can get symptoms of hypoxia when you have altitude sickness. So you're thinking, still don't see the connection. Okay, so if you have decreased cerebral spinal CSF, so we give a carbonic anhydrase inhibitor. It's going to decrease the carbonic anhydrase that's found in your choroid plexus. So you're going to get decreased cerebral spinal fluid production. This is going to increase your ventilation rate, because you're going to form a metabolic acidosis. If you decrease your carbonic anhydrase, you're going to decrease your CSF, you're going to decrease your bicarbonate as well. This all creates a metabolic acidosis. This metabolic acidosis will increase your ventilation rate, and that increased ventilation rate will increase your breathing. You'll try and get more O2, you'll have less hypoxia, so you'll have increased O2 saturation in the blood. You'll have to breathe in more to get more oxygen. You'll have increased oxygen. And then also, it can also be used as a means to increase urine pH. So it increases the urine pH. And what it does, it's going to trap acids in the urine. So remember, if you give carbonic anhydrase to the kidney, you're going to lose the bicarbonate into the urine. Bicarbonate is a base. It's going to trap acids. So if you have weak acids in the urine, weak acid is going to interact with the base. It's going to trap it in the urine, and that way these weak acids cannot get reabsorbed. So it'll alkalinize the urine. That way you can trap some weak acids in the urine, and then they'll be excreted instead of reabsorbed. So that's the very basics of carbonic anhydrase. This is one of the more important and more complex drugs to understand because all of its different functions and its different uses, it absorbs bicarbonate, and it's used primarily in glaucoma treatment. Alright, we're almost complete in our discussion about diuretics. We need to almost wrap things up with aldosterone receptor competitive antagonists. Okay, so an aldosterone receptor competitive antagonist, diuretic. What is our prototype? We're talking about spironolactone. And the buzzword that I really want to get out of this is you're going to have potassium sparing. If I say potassium sparing, I want you to think spironolactone. So K sparing. That is the one thing I want you to take away from this. Everything else is just extra. So let's talk about the mechanism of action really quickly, and then we'll get into a more detailed approach. So we have aldosterone production, and the aldosterone is going to be part of the renin-angiotensin aldosterone system, the little renin-angiotensin-aldosterone cycle. So if you have increased renin release, you'll have increased angiotensin. That angiotensin 1 goes to angiotensin 2, and that angiotensin 2 will stimulate the aldosterone release from the zona glomerulosa. So aldosterone is from the zona glomerulosa, and that's from your adrenal gland, so your zona glomerulosa of your adrenal gland. I do have a video on this if you want to just recap. Otherwise, that's about all you really need to know for this lecture. So we've got the aldosterone production. Now, aldosterone is going to primarily affect the principal cells in your DCT, in your distal collecting tubule, but mostly in your cortical collecting. I would star this. So your aldosterone is mainly going to affect your principal cells in your cortical collecting tubule, also your collecting duct as well, to a lesser extent. So we've got a cell here. So we're in that cortical collecting duct, and we see a cell. Here's another cell. Here's another cell. All right. So we're dealing specifically with this cell. We've got a pump that we've been talking about all morning now here. So we've got a potassium here and a sodium. And this is going to be our sodium, potassium, ATP, ACE, meaning we're going to need an ATP. But what we're going to do is we're going to drive a sodium out of the cell. In the meantime, exchange it for a potassium. That will go inside the cell. We've got a channel here that we've already talked about if you've been following along with my lecture. It's got the sodium bringing it in. It's just a channel. Here's our lumen side. Here's our interstitial side for orientation. This channel is called the ENAC, the ENAC channel, right there, and we've got a channel that's going to be affected by our aldosterone receptor competitive antagonists, such as spironolactone. So I'm thinking spironolactone. This is going to be a potassium sparing. So what we're going to do is we're going to increase this channel with aldosterone. I need to make a smaller pen. I'll get rid of this really quick. Okay, let's try this again. So aldosterone is going to affect this channel and this pump. Normally in the body, we're going to increase this pump or this channel, and we're going to also increase this pump aldosterone. However, we're going to give a drug It'll be an aldosterone receptive antagonist, meaning we're going to block the effect of aldosterone, to antagonize the effect. So if we antagonize the effect, so if we do a aldosterone receptor antagonist, I'll just abbreviate ARA, aldosterone receptor antagonist, it'll block that, so it'll actually inhibit this channel. It'll actually inhibit, ARA will inhibit this channel. And if we inhibit that channel, more sodium will get lost in the bloodstream. However, the potassium will not get lost, because here we're pumping potassium back into the cell. That potassium will leave here through a channel. Here, however, if we're not pumping it back into the cell, it can't go back into the lumen, so we're actually maintaining a lot of that potassium into the bloodstream. We're not losing that potassium in the urine, because everything that stays in the lumen goes into the urine. So if we have our sodium here, because we inhibit this channel, it can't go back into the cell, it'll stay in the lumen, it gets excreted in the urine. We're going to lose it from the body. This potassium, we're going to keep it. That's why we call it a potassium-sparing drug. The aldosterone receptor antagonists, the spironolactones, are going to be aldosterone sparing. So we're going to decrease sodium reabsorption, and we're going to increase potassium retention. Okay, so we're going to lose sodium, we're going to keep potassium. There are a couple uses. So uses for these aldosterone receptor antagonists, and the primary one is going to be diuretic. Also, typically used when the patient is in hyperaldosterone state. So in a state of hyperaldosteronism. Also, you may see it as a diuretic for heart failure. Primarily, this is what I would be concerned about. If the patient is hyperaldosterone and they have hypertension, then they'll increase their blood pressure. You'll want to give this as a diuretic to block the effect of that hyperaldosteronism. Thus, you'll lose your potassium, and water will follow. Since you have, or you'll lose your sodium. My apologies. If you increase sodium in the lumen, then water will follow. Water follows due to its osmotic gradient, and then you'll lose it in the urine. There are a couple adverse effects due to this drug. One of the possibilities is hyperkalemia, so hyperpotassium, hyperkalemia. And if a patient has high potassium levels, you don't want to use a potassium-sparing drug because you'll have increased potassium retention then. So hyperkalemia, in a patient with hyperkalemia, you could possibly get peaked T waves on EKG. That's a sign of hyperkalemia. Also, you may have absent or diminished P waves. That's a hallmark. Peaked T is a sign for hyperkalemia, while decreased P waves is also an indication for hyperkalemia. Also, an adverse effect would be like anti-steroid effects, because you could have like hormonal irregularities. You're blocking the aldosteronism. Aldosterone is going to be the steroid. You're blocking that receptor, so you're going to have anti-steroid effects, such as hormonal irregularities, for example. All right, one more diuretic to go if you're following along. Otherwise, thank you very much. So we're going to bring this diuretic discussion on home with a, let me pause my movie here, with a discussion on ADH antagonists. ADH antagonists. ADH is simply antidiuretic hormone, also known as vasopressin, vasopressin. ADH is going to be a drug that's going to have a lot of effects, and one of the effects is going to be on the kidney. So we're going to talk about drugs that are going to be ADH receptor antagonists. So they're going to antagonize, they're going to block the receptor for ADH. The prototypical drugs that we'll be talking about are going to be conivaptan and lithium. Just as a little aside, if you hear Vaptan, think ADH antagonist. Vaptan, ADH antagonist. And associated with ADH, ADH simply puts aquaporins onto the collecting duct. Aquaporins, aqua stands for water, pore, like a pore, so it creates a pore for water, and water will come back in. And I'll show you how the mechanism works there. So let's talk about that MOA, the mechanism of action. So we've got a cell, and this one's going to be, here's a lumen, here's an interstitial. We're going to talk about the collecting duct. When you hear ADH, antidiuretic hormone, I want you to think collecting duct, because that is going to be where all of this takes place. So here's a collecting duct cell. We've got another cell here, another cell here, but we're going to take a look at this one. So we've got a receptor, because remember that the point of this discussion, ADH receptor antagonists. So here's our ADH receptor, and we're going to antagonize this. But let's talk about normal physiology. Typically, ADH, so the vasopressin or ADH antidiuretic hormone, is going to come and bind to its receptor. That receptor is going to be called the V2 receptor, and what it is it's going to stick some stuff called aquaporins onto the luminal side of the membrane. The aquaporins, like I've already said, are a pore for water. So we have all this water coming down. So here's our picture. Here's our glomerulus filters. Here's our proximal convoluted, descending, loop, ascending, distal convoluted, and now we're in the collecting duct. And that collecting duct will eventually lead to a ureter. That ureter will lead to the bladder and then the excretion. Oops, didn't mean to do that. Let me just draw this in really quick. Okay, so what we're dealing with is right here. We've already reabsorbed stuff, I'll just say solute stuff, here in the proximal, down in the descending, in the ascending, in the DCT. Everything that's left right now is going to be like water, sodium, maybe potassium, maybe chloride. So we have a whole bunch of, just for our sake, we have water and sodium, because water always follows where sodium goes. So if we have sodium, we most likely have water. So here we go, in the lumen. It's destined for the ureter. We're about to lose it. We're in the collecting duct. This is our last chance to get it back. So ADH, anti-diuresis hormone, antidiuretic hormone. What does the name tell you? Well, it says that you're not going to diurese. You're not going to pee. You're anti-diuresing hormone. So that means we're going to somehow decrease peeing. And we're doing that by increasing these aquaporins. Those aquaporins will be like water pores. The water will be able to go through these pores and get reabsorbed. So we have less water in our urine. We'll have more solute, however. So our increased osmolality of our urine will increase. We'll increase our urine osmolality because we're decreasing our water. We're reabsorbing our water. This is our last ditch effort. We're in our collecting tubule. The ADH will agonize the V2 receptor. It'll stimulate the aquaporin release to the membrane here. These aquaporins cause water reabsorption. So these V2 receptors, the V2 receptor is found on the interstitial side of the membrane, while the aquaporins are found on the luminal side. Just as a little aside, I said V2 receptor because you have like the V1 and the V3, and that's going to be found, like the V1 will be found on like the blood vessel, the V3 may be found on the pituitary, etc. We're talking about the V2 receptor, and this will be dealing with the kidney, because remember ADH is also known as vasopressin or angiovasopressin. That'll be on the blood vessels as well. It'll affect the pituitary. However, this one is affecting the kidney, the V2 receptor. And then these aquaporins, just as a little aside as well, aquaporin 2 channels. Not a big deal. So when do we actually use these ADH receptor antagonists? So over here, what we'll be doing is we'll be antagonizing it. We'll be creating a block. So we have this ADH receptor antagonist, also known as like a conivaptan, like our Vaptan drugs. What they'll do is they'll come in and they'll block this. They'll create a little shield. Our ADH can't work, so we can't reabsorb water. We'll pee it out. So it's a diuretic. So where do we get these ADH receptor antagonists? When do we use these drugs? And there's really one main use where we'll actually use the ADH antagonist, and that's going to be SIADH. Now, what in the heck does that mean? Syndrome of inappropriate ADH secretion. So we have syndrome, so we'll have symptoms, we'll have a syndrome of inappropriate ADH secretion. We'll have increased ADH secretion. So if we have increased ADH, we'll have increased ADH effects. We'll have blood vessel effects. We'll have kidney effects. And in the kidney, like I said, ADH is going to reabsorb water. So if we have SIADH, we'll have really concentrated urine because we'll be reabsorbing all of this water if we have increased ADH. So we'll use the receptor antagonists if we have too much ADH, and we'll antagonize the effects, pretty much making ADH not useful in the kidney. Alright, so that'll conclude our discussion on diuretics. If you have any questions, be sure to ask. I always enjoy getting comments, getting likes. Likes always build up my ego. And also subscribing also builds up my ego, but also it'll give you great videos in the future. Thanks for paying attention, and have a good day. Thanks, guys.